So we'll get started. Good afternoon. I am David Taylor. I'm a physical therapist and a member of the faculty of the Department of Physical Therapy here at Mercer. With me today is Dr. Susan Miller. Susan is a pharmacist and part of our College of Pharmacy. We're both on the Atlanta campus. Other members of our team are Leslie Taylor, who's also a physical therapist, and then Jennifer Dela Cruz, who's a physician assistant. So together, we are Engage, part of Georgia Gear, which I'll share with you. And what we really wanted to share with you was an initiative that's out in clinical practice that we're passionate about, which is age-friendly healthcare. So we're all focused on the care of older adults, or if you're looking at it from the more medical definition, geriatrics, broadly there. So what we want to do today is sort of just introduce this age-friendly healthcare initiative, talk about your path to becoming an age-friendly healthcare provider, and then answer any questions that might be delivered or come up for you guys here. So first, because what we do is part of a grant our Engage group is interdisciplinary. It's a College of Health Professions and Pharmacy. The vision is this will expand to the College of Nursing and include our College of Medicine as well. And we're really grateful to be here today because through Dr. Bocros and her group, we have a lot of students here at Mercer that are interested in health sciences programs and pathways. So we're sort of giving you a preview of what we expect you'll be dealing with as part of your curriculum should you choose Mercer. And because this is part of a grant here that we're part of with Georgia Gear, everything that we do is really open access. So it's none of the stuff we present is Mercer stuff because of our grant funding through HRSA here. So it's going to be open, and we hope that other programs will take this up, and that we would hope that when you go to whatever professional program you're looking at, you'll have a sensitivity to being age-friendly, because we can guarantee that you will work with older adults as part of your healthcare training. So,
just a few questions for you, and I realize we'll just kind of ask the question out. I realize we'll just kind of a few questions for you as the audience. Maybe you could think about this question if you're not here physically to answer it. But what profession are you, what healthcare profession are you pursuing, and why?
You get to be our answer. I'm pursuing physician assistant for my healthcare pathway, and it's mainly because I really want to be a part of like an overall healthcare team that helps like deliver like services to marginalized groups.
All right, so the answer from the live audience was the interest in physician assistance programs and to provide care to groups, particularly marginalized groups. And you could make a case that older adults could be a marginalized group for various reasons. So the next question would, how would you define the term older adult? You better not say 40.
and that's sort of what we want to get at. We want you to think about like what your frame of reference is. So I'll tell you, I'm 56, and I don't think I'm an older adult. But depending on the definition or operation you look at, it is. But when I talk to kids in elementary school that may be 10, my gray hair, the fact that I'm significantly older than they are, they're thinking, well, you're definitely an older adult to get things there. So,
and I'm over this 65. That's in my rearview mirror. So I've passed that. And again, I still wake up and think in the morning, I can't believe I'm age. Sometimes I feel it at night, when I get home from work, but I still work full time. So again, what is age? What is age and what is an older adult? We use the term 65 here in the United States because that aligns with eligibility for Medicare. And I've heard this said, and I don't know if it's true or not, that age was picked because they thought people would not ever live to be that age, or not many would. So basically they would take our money, stow it away for Social Security, but then never have to pay it out. Well, we fooled them because of our healthcare system and the opportunities that we have, that many more people now are living to that age. In fact, we call that young old. And many people are living 25 and 30 years beyond that. So older adult is kind of a big group of people.
Sure, and the other thing I'll bring, when you think of individuals that, as you may think of the type of practice you want, when I got into physical therapy, I was gonna do sports medicine. That's what I wanted to do. I went with athletic population, and then I ran into some older adults that I got more out of working with the older adults than I got out of working with the young athletes. But when you look at sort of lifespan, even the pediatric age group, that's 0 to 21 years of it, so 21 years. But if we start at 65 and you go to 100, your Mercer math should be able to tell you what that number is, right? But it's more than 21 to get there. And then the other bullet point here, when we look at this from a global perspective, and it's that 60-plus years of age. So I would imagine that as you guys prepare to enter your practice in healthcare, what this term is, the lower limit, is probably going to be right at 60 as we start to look at things. But as you get older, everything is the new 60. So 70 is the new 60, 80 is the new 60, 90 is the new 60 as we go forward from there.
And just one other thing, aging is very individual. And, you can get into discussions on, physiological age, chronological age, and a lot of the things that we do early on affects how we age. And then there are those things that are beyond our control that are built into us that we can't, but, well, maybe someday we may be able to make some changes there.
Yeah, so as you choose to enter your practice, everybody has a role in preparing everybody for the aging experience from there. Now, a couple things just about older adults, and we often get, well, why? Well, why? Because we said so, and we said it's important, so you should do it. But more than that, there's populations issues. But here's just a couple things, and these statistics come from the federal data, right? So falls are dangerous. Falls are a practice area of mine, right? In 2017, 34,000 deaths. That's a big deal if it's someone that's important to you or is your patient. 3 million ED visits, right? So all of our health sciences disciplines here at Mercer either can practice directly in emergency departments, okay, or are working with those in the emergency departments. And then just the medical costs, $50 billion a year direct medical costs for just falls. That's just it, okay?
And ED visits, again, pharmacists now have a place in the emergency department, taking drug histories, watching for drug interactions, so there is a becoming role of pharmacists in ED. But on to medication, the average 70-year-old takes 5 prescription medications. And it takes at least 2 medications to have a drug interaction. So again, some more math. What's the probability of a drug interaction with 5 medications? So that does not include the things that people don't consider meds, which are over-the-counter products, things that you can buy without a prescription, and the growing emphasis on dietary supplements and natural herbal things. Those all can interfere with medications. And more than 1/3 of all prescriptions that are filled in the United States are for those 65 and older, but yet they only make up this group only makes up about 12 to 13% of the whole U.S. population. So a lot of students that I talk to in pharmacy have an interest in pediatrics or children, and I tell them that's fine and good, and many times they have that interest because of an experience they've had. They may be a parent themselves, or they just like to be around children. But that truly is a specialty, whereas the older adult, the vast majority of your prescriptions that you fill and counsel on and address are going to be for that older adult in that huge range of 60 and above.
And it's a medication, again, is cross healthcare disciplinary. It impacts all of us regardless of your discipline. So the ability to know how these medications interact with an older person becomes even more
And one thing I've learned with working with my physical therapy colleagues is one of the first things that they do in a visit, whether it be a home visit or a clinic visit, they get a med list to see what meds they're on again, to get a picture of how that may be affecting that patient's status.
Yep, so we talked about falls, just other things, and I think this is relatively common knowledge. The number of older people in the United States is getting greater and is projected to get greater. So it puts potentially more burden on the healthcare system, depending on how you want to define burden, but definitely more users. So if you're looking for a good group of individuals to work with, the population is going to be there for us, according to the census data. Now, I looked at this specifically from Georgia. In Georgia in 2021, almost 11 million individuals over the age of 65, so about 14%, so a little bit higher than the U.S. population. And I can tell you that from my professional experience, there is a lot of growth in the aging industry here in Georgia. A lot of older persons moving to Georgia for continuing care retirement communities, and they come here to Georgia, one, because it's just a great place to live, but because we have outstanding health care, we have access to travel, and frankly, a lot of their families are here. So it makes it easier to see that bigger family, grandkids, support things, and there's employment opportunities for you here in Georgia as you age. And then 12% of Macon's population, so reflective of the national population or older adults. So if you're doing healthcare related things here in the greater Macon-Bibb County area, you have a good chance of working with an older person there. Another thing here is just life expectancy. So Dr. Miller sort of alluded to that a little bit, but again, life expectancy post-COVID, we know dipped a little bit, and this data here will sort of give you from a certain point, how much can you expect? In our work, we want to prepare you better to address the needs of older persons across that entire lifespan. Another concept you might run into is life course, so that journey through life, as well as health span. How much physically active and well time do you have? You can have life with illness, and it may not be what that individual is looking for. But the data is still supportive of women outliving men. So you should expect to see more female patients as they age than you would for male patients. Oh, yeah, this life expectancy when you get into, as our student talked about earlier, like underserved, marginalized populations, unfortunately skews significantly to different ethnic groups, as well as some regions of the country where healthcare services may not be as accessible to Americans. Okay. A couple other things just that influence care we'll talk about with our, we have a fantastic College of Public Health, a School of Public Health here. So the social determinants of health. So poverty is going to impact aging, and people get elevated poverty as they get older, specifically when you get 85 or older, right? A greater percentage of Americans there. In all of our worlds, and me specifically as a physical therapist, functional limitations, okay? The inability to do your life skills, participate in the activities that you want to engage in, with who you want to engage in, when you want to engage in them, okay? So about 22% of individuals are going to report those functional limitations. And then back to the healthcare costs, and this is specific to prescription drugs, that $4,500 number there is really looking at the potential costs over a course of a year from there, okay? The other thing you have are the most prevalent health conditions that we will treat that are in there, right? Cancer doesn't necessarily pick a lifespan group to work with. Heart disease doesn't do the same thing, but these things are more prevalent in people as they age and grow there. Anything else you wanted to add there, Dr. Miller?
No, prescription drug costs, of course, we can talk about that forever, and nobody understands that. But that is a significant piece, and we can work through all of our disciplines to make sure our patients have access to medications, they are affordable, and some strategies to trim down these drug lists and all. So we work collaboratively with our other team members to make sure that the people are on the most beneficial meds and that they have access for them.
So we're trying to lay that foundation that it's a team that is best suited to care for the healthcare needs of an older person, and we have to sort of know our roles and responsibilities within that team.
And just a kind of a sidebar on that is all of our curricula, our students in the healthcare, health sciences are involved in interprofessional education. So you will meet with and solve cases and have conversations with students in all these other, in fact, there was a call at 3 o'clock today. I'm the College of Pharmacy's rep on that university committee. We've just had our 2 big programs for this year. But you will be involved in this team, so you will learn the responsibilities of other members of the healthcare team and how they fit into care, and then how you and your role would fit into that care.
And then as we look at this, another question we want you to think about is, when in your sort of pre-professional training are you going to encounter older individuals to work with? So I'll ask that question of our audience right now. When do you think you will, or have you encountered older individuals in the context of healthcare?
I work as a certified nursing assistant, and so I work in long-term care facilities, nursing homes, and I also work in the ICU. So I encounter older individuals often, very often, and so that's one of the reasons why I'm here, is because I'm really interested.
Okay, great.
And I've interviewed students for the applicants for the Doctor of Pharmacy program that are here on the Macon campus, and many of them report working as a pharmacy technician. So they work in pharmacies here, and again, they're going to encounter, that would be another way that an undergraduate could encounter an older adult.
Yep. So the example we got from our audience here was just working as a CNA in both long-term care and then acute care, intensive care settings. The other thing I want you to think about is everybody that's well and aging. That's still healthcare on a prevention standpoint. So if you're out doing service learning-based activities that are in the community and someone's painting or dancing or engaging in a Tai Chi class or just doing something fun, right, around campus here, look at that individual for not being ill, being well, because I think that's one of the important areas we have to focus on in the care of the older person, is to keep people sort of away from how much they need to utilize the healthcare system. In your professional program of study, I can guarantee, as I said, you will all work with older persons. Our team has a belief that in your professional program, you're trained to be a physician, a pharmacist, a physical therapist, a physician assistant, a clinical psychologist, a nurse. We give you the tools to go forth and decide, I'd like to be a geriatric pharmacist, a pediatric physician assistant, right? But the intent of our professional training program is to arm you to go forth and do, not necessarily to graduate as being a specialist. And then as you enter practice, you'll choose the areas that you want. Our example from long-term care, if you work in a long-term care setting, there's a strong probability the pediatric clients you will see will be visiting the individuals there, okay? Not under your direct care. If you work in the emergency department example, emergency departments are not lifespan specific, but there are geriatric emergency departments across the country where more specialized care is available, and I don't believe that here in Macon we have a Geri ED that is up and running here.
So the quick backstory, how we got here, there is a designation of an age-friendly health system. And back in 2017, the John Hartford Foundation, which is a philanthropic organization that funds a lot of different projects, but a lot of them seem to be in the area of older adults. They partnered with the Institute for Healthcare Improvement, which is a national institute that puts out policies, guidelines, recommendations on safe medication practices and all kinds of other stuff. But it's a very wide-reaching, broad organization. So those two partnered together with some hospital systems, the American Hospital Association, the Catholic Health Association of the United States, and they came up with this concept of age-friendly care. And they promote a framework or model of essential elements to support high-quality care for older adults. And it's based on these things: the health system, the family caregiving, and then serious illness and end-of-life support. And you, as a health system, can be certified, and there are at least 2 health systems in Atlanta that are certified as age-friendly health systems. And so we're trying to push it kind of from the ground up to train our healthcare professionals to maybe take this concept forward in their working life. If their system is not age-friendly, that they can open that door for that.
Yeah. As well as preparing you to be successful should you choose to go and work in an age-friendly health system. So one of the systems we're talking about in Atlanta is Grady Memorial Hospital, right? So they have a lot of systems in place, have the designation to support the care of older adults.
I think Emory's working on it. I don't know that they have an affiliation with Grady, so they're working on it. There's a list that you can get, and it's published. And there's a clinic, a PT clinic on the Atlanta campus, and we've started the initial paperwork to have that certified as an age-friendly clinic.
Yeah, so if we get that, we think we'll be Mercer's first age-friendly system. So it's got to start somewhere. So the other parts about this, sort of the framework we're walking out, and things really, if you asked us, what's a take-home today, other than I will care for older persons, older adults as part of my healthcare training, I have to be prepared to do that. Mercer will be working on arming you to do that, is this concept of the 4 M's, okay? So the 4 M's are what matters: medication, mentation, and mobility from there. And this is the context that we want our health sciences graduates to look at any and every older person that comes into their care. Okay? These modules, the 4 M's, could have a higher priority. So for me as a physical therapist, boy, the mobility is low-hanging fruit. That's the go-to thing. That is what I do. For Dr. Miller, I'm going to ask her about medications to make sure that they're right. We all need to make sure someone's mentation is there. What we're talking about with mentation is dementia, delirium, and depression, okay? Beyond that, cognitive impairments that can be age-related or disease-related from there. But most important to these really is what matters. What matters to the patient. So we want everybody that graduates from our health sciences program and they encounter an older adult to be really asking explicitly to that person or their caregiver or their family member, what matters to you? An example for my work is, physical therapists are associated with walking. That's what my kids would always say when they're little. My dad makes people walk, and I would disagree that I don't make people walk. I help them walk or ask them to walk, okay? But make them walk better, okay? But there are times that individuals, that's not a priority for them. Their priority is to be able to be up and engage with their environment, to see their grandkids, do different things. But the walking part, not as important from there. So we want everybody to look at these older adult clients that we have or patients through this lens, but not separate any of it. So these are really 4 questions you should ask when you encounter an older adult. What matters to them related to what we're seeing them for? How does medication affect what matters to them?
Because you can give medications that cause drowsiness. You can give medications to relieve pain. You can give medications to fix one thing, but the side effect is altered mentation. So what matters, again, that's how the med goes in there.
Yeah. And so everything is going to come back to that, what matters, okay? And then as that individual's healthcare team, we want to prepare everybody to say, our physician assistant is the best person to manage this issue right now, okay? And it could be a medication issue because they're having that discussion after consultation with the pharmacist that this is what's going to be best for this individual given this state of health.
Another example would be medication. We are all familiar with diabetes and the use of insulin. Do they want to stick themselves to give the insulin and then check their blood sugar 4 times a day? Do they want on these pumps? Can they afford this? So all of those questions go in there to what matters to them. They don't want to walk around with Band-Aids on their hands. Can they read the meter? All of those things come into the decision for that one thing, but it needs to be what matters to that patient.
So this slide is just showing you more definitive sort of definitions of those things. But again, the key for us is everything really comes back to what matters to that individual or their caregiver and their family, the individual specifically there.
That is one of the core values of most of the professions I advise for is patient autonomy.
It is.
That's exactly
It
right.
is. Yep. So we just want to make sure that that is occurring. Again, you're going to bring this up. The issue of optimal health care for older persons is not a new issue. This has been talked about for years and years and years, okay? But what we know is that there's a lot of older adults that require health care. There's not enough health care providers that have adequate and advanced training, and I will go back to the adequate piece, to provide optimal care for the older person as they negotiate their path through the healthcare system.
And a lot of, you brought up the issue of autonomy, and that certainly is very important, and we talk about that. That's one of the things that I manage, or I talk about ethics and those decisions within the pharmacy curriculum. But what happens, and I've seen it more and more, is a lot of things now are protocol driven because of insurance payers or whatever, checklist, is my practice gonna get this gold star, what's their rating? And so if you get, as a caregiver, stuck in that protocol, but you're not listening to your patient, that's what we're trying to make that awareness, that you need to listen to your patient.
Yep. And the other point that I think is important to take from here is we talk about a healthcare system. We're not necessarily just talking about the hospital, the acute care. We're not talking about the medical center at Navicent only. We're talking about the medical center at Navicent, Navicent Rehabilitation Hospital, all the outpatient medical clinics and services that are offered through that, all the way down to home health care that's delivered through that hospital system, and then on to what the system is doing to help people stay well in the community.
And the individual providers within that system as well.
Exactly. So we all have different places that we can choose to work within the healthcare system. This model, this framework is intended to be inclusive of it all as we go through there. A little bit here on some sort of barriers to age-friendly care. So with our audience, I'll ask, what's ageism? Right? And that's, so discrimination against older individual, and again, and it's because of their age. Okay? It doesn't mitigate any of the other isms. Okay? Sexism, racism, all those sort of things. But it is one of those things, but it's sort of a barrier. Okay? There's different types of ageism. Okay? There's hostile ageism. Okay? Unfortunately, hostile ageism is evident in YouTube videos, and as Dr. Miller and I deal with a little bit more of the medical legal stuff within our professions, where someone that may have cognitive impairment or dementia and mobility problems can't assist in their care. We talked about long-term care, and being a caregiver is very hard to get things done. And there may be abuse or neglect that goes on from there. Okay? There can also be benevolent ageism. Okay? Can you think of an example of benevolent ageism that you might have done or encountered?
Maybe like not abusive, but I mean, it's
Okay.
I know one that happens to me when I go into a pharmacy or something and somebody calls me Miss Susan. Number one, I probably taught them, so, but that's another story. But again, those pet names, that's a minor example, but that approach and darling and all that, just the way you approach, treat them like a child, that's one thing.
Yep. So our words matter. In my world, from physical therapy, and when you look at physical activity, it's underdosing. Oh, that person is 92 and they're frail, they won't benefit from exercise. That's exactly the opposite of what the literature says and what we know clinically. No, they should not be doing a full kettlebell workout on their very first encounter with you, but if you dose it appropriately, they will get stronger. At the very least, they won't lose muscle strength or function. So that underdosing there, and this is a little bit of a physical therapist bias, when medication's prescribed, potentially it's misdosing that. And one of the concepts that Dr. Miller can fill in better than me is the whole aspect of deprescribing from individuals that can prescribe medications.
So you look at their med list, and why are they on this? Nobody knows. Somebody prescribed it years ago, and physicians or prescribers are reluctant to take away something that somebody else has done. So they get this huge med list. But again, what you can do to help them is to get them on the exact meds that they need. Another example from the medication side is warfarin, a drug that we use quite often post-stroke for anticoagulation. And caregivers, prescribers are very reluctant to use that in older people at the right dose, so they kind of underdose it. But again, the literature has shown, because they're afraid they're going to bleed, but if you dose them correctly and monitor the labs correctly and make dose adjustments that pharmacists can do really better than a lot of other healthcare professionals, that's the drug they need to be on. But you see that underdosing all the time. And then the other one is pain, not responding to pain and treating it appropriately. Again, underdosing pain. And some of this stuff is, well, that's just a normal part of aging. You know, blurry vision is a normal part of aging, so we'll just let it go. And the inability or the problems walking and maneuver, that's just a normal part of aging, just let that go. And that's not necessarily correct.
Yep, and and there's been a lot of discussions lately about explicit and implicit bias, specifically it relates to healthcare. We believe this occurs with older adults as well. And so one of the things we'll be working on is trying to give people tools and resources as best we can to sort of mitigate the impact of ageism as healthcare is delivered to older persons. So what are our goals here? We have about a 5-year grant, so we're getting things wrapped up. Again, we want our students, our preceptors, the community to consider that 4 M's at each patient encounter. So at that very minimum, we're going to ask these 4 questions that an individual, and am I and is my team meeting this individual's needs from there. To do that, we've done some things. I mentioned earlier that language matters. We've created a glossary of age-related terms. It's available through the Mercer Library System. So everything from, definitions, operational, and what we plan to do is work from these definitions that are well described in the literature so we can be consistent across disciplines. So, for example, medication management, medication therapy management is one we talked about, and MTM, right? So I think, well, I'm doing medication therapy management. Well, I'm really not. I'm doing medication reconciliation to get things done. So we can have consistent thing, and we hope that this will be used across our health sciences program. So, for example, in my role, we all use the same definition of a fall. It's not what you think a fall is. This is what a fall is. If it's not this, it's not a fall, okay? And then we can go in and talk about how each of our disciplines would manage that and everything that goes through it.
Polypharmacy, everybody has a definition of that, and there are actually 2 definitions for that, but we have those in there. Frailty, I'll ask early student pharmacists, what does frail mean? They go broken bone. No. It's actually a clinical syndrome, So we picked, a lot of these are considered syndromes, which are those things that are often overlooked in the healthcare system as somebody else is going to manage that, or not my problem, or that's a normal part of aging. So we've picked those syndromes, and then we have the overarching topics that we'll be providing as well, those ageism and age-friendly health system as a topic.
Yeah, so the overall hope is that we can say that every health sciences student will have access to information on age-friendly health systems, understand the framework, educational resources to support to combat ageism, and then of these geriatric syndromes, because they are clinically complex. That's what makes them hard to manage and require that interdisciplinary team. That the foundational educational piece is we'll all start together of an understanding of what polypharmacy is. Now, as a physician assistant or a physical therapist or a pharmacist or a clinical psychologist, all different on how we manage it in our practice and work together. but we're going to start at the same point and build from that, and these resources will then be available to the Mercer community and then the greater community out there. And again, when I say the community, I mean graduate, undergraduate. It's non-proprietary stuff from there. So it's sort of in conclusion here, again, to quote Helen Keller, alone we can do so little, together we can do so much. And that comes from our belief that it truly takes a team of professionals working together to provide optimal care for older adults. Our role in this continuum is we have to have people ready to enter these health sciences professions and practice if we expect you to be able to deliver this care.
And some of the other things that we're talking about, we haven't fully sorted out yet, was if all the health science students complete these, would there be some kind of badging or some kind of notation or certificate? Those are all big topics we have to talk about, but we're looking to do that so that you can have that credential to carry with you.
So that's it. So any questions from the audience?
Well, I'm curious if clinical psychology is involved with this too. They're participating as well, aren't they?
They are. So eventually it will be all sciences. It started because, like many grants, you have to have people that are willing to do it, and we're part of a bigger grant. And
The grant originally is from Emory, at Emory University, so we're a subcontractor, and they needed some things that Mercer had, some of the curricula that we had, so they approached us. And then the core group was the PT, PA, and pharmacy. And then we're bringing these others on, and clinical psychology has come on board through actually a graduate student, but we've done what they're with us now. And like I said, we're working with medicine and nursing to come along as well.
But again, the idea is it will be rolled out to, if you're a health science program at Mercer, you will see this would be the ideal, and your faculty will all have access to these resources, as would you as a health sciences student here. Yep.
But we're real proud of this glossary that he was talking about. It's actually one of the library guides, and we've hooked it or attached it with all of the different programs. So there's a pharmacy piece, there's a PT, but it's actually there. And this is available for public use, right? For public use, because it's a product of the grant. Let me see if can we do this? See what happens. Yeah, here it is. So it pops up, and then you can see, I'll pick my polypharmacy. The prescription, administration, and/or use of more medications than are clinically indicated in a given patient. Often referenced as the use of 5 or more. That's what you see very often. Polypharmacy is when more medications are used than needed despite the number, so whatever the number is. And we've got a link to deprescribing in another article. Pharmacokinetics, pharmacogenetics, pharmacodynamics, all these things. We're going power of attorney, what's Medicare, all of these different things. What's one that you want to put? Let's put falls. Let's go back to falls.
But again, it gets back to trying to use the same terminology. Let's define it at that's what it is, and then build from there with the references. And it's a living document with resources that are attached.
Fall is an
to it.
event which results in a person coming to rest inadvertently on the ground or floor or other lower level.
There's no actual height requirement.
Techniques, fall prevention, and then fall risk and fall screening. So there's, failure to thrive actually is a term from the pediatric literature, but it's been moved into the adult, particularly geriatric literature, in probably the past 10 or 15 years. So we're moving things around. But this is what this is. You can look up a lot of things.
It was a little bit of work
About a
to
year.
get it done.
Yeah.
But again, we want it to be sort of a living document, so if we get something from our colleagues in other programs, like we think this is important. And we did sort of a peer review, so it could not be one discipline centric, and it's not exhaustive. That's just not
No, can't be that way.
not possible.
And this is our logo, Engage, and there's a couple things hidden here, the age, is in there. Get involved, so engage with this program. And this little logo here, you can kind of see an E in the circle, so, and then this is Georgia Gear, which is the larger group that again is housed at Emory, but we're all in all that.
Yeah, and then if you look right in the middle of the end, the age is important, but the GA is very important to
There
us
you
in
go.
there.
So
That this is,
Georgia.
this is about older adults living in Georgia. That is our focus, from Hiawassee to Blackshear, you know, to get those things.
That line.
Get those things.
Okay. All right. Okay.
Yeah. So if you're going to be attending a Mercer Professional Health Sciences program, we're hopeful that you will engage, pun intended, in this, and know that there's other individuals that are across all faculties and all the programs that have a specific interest and desire to make the care of older adults better. So we are all faculty here. Our email addresses are all available on our college web pages. If you have questions, we'd encourage you to reach out to us. We're happy to help you as much as we can. And thank Dr.
Glad to have this connection. I think Dr. Taylor had it earlier, but I'm glad to have it so we can have this connection.
I will stop the video.
So you're looking at Mercer for PA school, or you're looking at PA school wherever I can get in?
Schedule to finish.
Because it is